So I'm going to talk about targeted therapies for melanoma. Many of you will be aware that across all melanoma, cutaneous as well as ocular as well as mucosal, the disease has had a reputation for being refractory to old-fashioned treatments, to the standard chemotherapy and radiotherapy. And what's happened over the last only 2 to 3 years is we've had major advances in the treatment of cutaneous melanoma in 2 areas. One area is using targeted drugs which inhibit particular molecular targets within the cancer cell, and the other area is with immunotherapy. So I'm going to talk about the targeted drugs and how they may have an impact in ocular melanoma, and Professor Ottensmeyer is going to cover the immunotherapy. And so hopefully at the end of it you'll have a feel for how these 2 different approaches potentially could start having an impact into the treatment of patients with advanced ocular melanoma. So I'm a medical oncologist, and unfortunately I spend my time treating patients whose disease has already escaped from the eye and has spread to the liver and other places. And for many of those patients, they need treatments that cover their whole body, because we know the disease is in a number of places, not just in one isolated place. So a few years ago, or certainly when I started practicing, we used to treat all melanoma patients in the same way. So whether you had cutaneous melanoma or ocular melanoma or mucosal melanoma that spread around the body, everybody would get a chemotherapy drug, and that was about it. And there was always knowledge that some patients' disease was behaving differently from others, and some patients had responses, but the majority didn't. But everybody was treated with the same stuff. Now in cutaneous melanoma, there was a recognition coming out of some work from the States, from a chap called Boris Bastian, that the genetic changes in the cancer cells were not identical between different forms of melanoma. So with cutaneous melanoma, whether you had a melanoma that was starting in a place that saw lots of sunlight or intermittent amounts of sunlight, or started on the palms of the hand or the soles of the feet or under the nails, what Boris Bastian's lab showed was that different genes were involved at different frequencies in driving those tumours. And when I talk to my patients about a gene that's being mutated, that's going wrong inside a cancer cell, I normally use the analogy of a switch that's gone wrong, that's been stuck in the on position when it shouldn't be. It's been mutated, it's been altered, it's stuck in the on position. And the effect of that is to stimulate the growth of the tumour. And so what Boris Bastian's work did was show in melanoma, different forms of melanoma have different switches that have been stuck on in the on position. And that's important because we're developing drugs that are specific for each of these different genes, each of these different switches. So you don't really need to know the details of which genes are involved, but you can see that non-chronic sun-damaged skin, chronic sun-damaged skin, acral melanoma, mucosal melanoma, you can see that the colours in these columns are different, and the frequency of these different oncogenes differs across these different sorts of melanoma. And you can see the standout one here is this dark column, which is the BRAF gene. And the BRAF gene has made, or treatments directed against the product of the BRAF gene, has made a huge impact in cutaneous melanoma. I'll show you an example, because this is a patient of mine who's a little 43-kilogram lady in her 80s who had this very difficult disease, locoregional cutaneous melanoma. And she'd had multiple treatments. You can see lots of surgical scars. She'd had chemotherapy. She'd had a variety of experimental techniques. She'd even had isolated lymphofusion, where chemotherapy is given to the limb, and that's a very similar rationale to the sort of isolated hepatic treatments that you've heard about from the preceding talk. But everything grew. And it turned out that her melanoma carried this mutation in the BRAF oncogene, and we treated her with this BRAF-specific drug, and you can see 8 weeks later these have all shrunk down, and she's continuing to have a response a year and a half on. So I'm showing you that just to illustrate the point that if you've got the right drug for the right molecular target for a cancer cell that's become addicted to that target, then you can have a major therapeutic benefit. And so, obviously, for ocular melanoma, the question is there anything equivalent that we can build upon to take advantage of this sort of approach? So there are some specific challenges with uveal melanoma. And they're mainly around the rarity of the disease. Because of the rarity, the understanding of the biology has tended to lag a bit behind some of the other cancers. So that's a challenge. And because of that, the evidence base is small, and most medical oncologists are very evidence-based driven. I find it very difficult to advocate a patient of mine having a toxic treatment if I can't look them in the eye and tell them what their chances are of benefit. I'm not interested in anecdote. I'm interested in trying to show patients what their options are based upon evidence. And where there isn't evidence, I think it's important for us to generate the evidence that's required so that we can honestly say to you what the best treatment is, and not just do it out of prejudice. So the evidence base is small because this is rare, and because the frequency of patients is small. There are real practical challenges in delivering clinical trials. There are many breast cancer clinical trials in which thousands of patients have been accrued into clinical trials to show benefits of 3 or 4% in a new treatment. And we don't have the luxury of being able to do that sort of clinical trial in ocular melanoma. Because there are very few patients around, the only way you can get a sensible answer out of a clinical trial is generally if the effect of the treatment is large. Because if you've got a small number of patients, you need to have a large treatment effect to show that to know for sure that the treatment is helpful. And so there is a real practical challenge in delivering clinical trials when you've got effectively an ultra-rare patient group in comparison to other cancers. And larger trials require international collaboration, and that's a real test of organisation, and sometimes a test of egos as well. So those are all issues for us. Now, I think in the UK, I think we've got a lot to be proud of, and I'm not just saying this because it's a UK audience, I'd say it to an international audience. We are following the NHS cancer plan. There are cancer networks established, there are 30 odd around the country. And there are disease groups under the auspices of the National Cancer Research Institute. And the Melanoma Clinical Studies Group, I think, is one of the most productive and functional of those groups. And when I mean functional, what that means is that we work together and we don't have a problem referring our patients to wherever we think the most attractive options are for them. And because of that, that's important for a rare cancer, because it means that if you're going to do a clinical trial, often it's better for those patients to be treated at a centre that sees a lot of patients rather than a centre who's only treating 1 or 2 patients a year. You'll appreciate that with any walk of life, if somebody's doing a lot of something, you tend to have a bit more confidence, perhaps, about the quality and the inherent quality control. And so with a rare tumour type, making sure that patients are referred into the active centres who have got experience with managing the patients and experience with the drugs is important. So within this functional network, we've delivered 2 recent phase 2 studies over the last 5 or 6 years or so. They're not earth-shattering in terms of results, in terms of changing the field for ocular melanoma patients, but they are really important, and I'll try and show you why I think they're important. These were the 2 studies, item with Imatinib and SWAV, which was a randomized study with Sunitinib, comparing patients with receiving Sunitinib to those receiving dacarbazine. These were studies that a partnership that I have with Ernie Marshall up in Liverpool developed over the years. We found, after we started to working together, that we both supported the same football team. It didn't come along before. So these studies were run out of Liverpool, and they were important in that they showed that we could develop studies and recruit patients. These were the first studies in the UK that were UK generated that ocular melanoma patients went on to for drug treatment. There was previously one other study that was an ERTC collaboration. So the fact that we've demonstrated that we can run these studies is important, because it means that we have now got a whole a number of other studies coming through to us, which I think is important in providing new options for patients. The other thing that a negative study does is it stops you poisoning patients with drugs that aren't going to help them. So there's quite a lot of buzz out of Philadelphia that Sunitinib was an important new drug for ocular melanoma patients. Sunitinib is a drug we use for kidney cancer. It stops blood vessels growing. It hits a molecule called c-KIT, which is sometimes activated in ocular melanoma patients. And there was a series of patients from Philadelphia in which outcomes for patients receiving Sunitinib look good. It's a good example of why the sort of single-arm studies that you often come across with ocular melanoma can give you a false impression. So Sato from Philadelphia has a series of patients receiving Sunitinib. They weren't compared to any other patients, and he reported the outcomes. If you just take patients and offer them a drug without a comparator, it's very difficult often to interpret those results, because inevitably there's a degree of patient selection. You know, the patients who can make it to Philadelphia and who are fit enough to get onto the phase 2, the clinical trials that they were running with Sunitinib, were very much likely to do better than the majority of patients, because they've selected themselves by being able to get to Philadelphia and be fit enough to have the drug. And so the only way to know whether or not a drug is helpful under those circumstances is to do the comparator. And classically, you need to do the comparator against the standard of care, and the standard of care was dacarbazine chemotherapy. And the SWAV study showed that Sunitinib isn't superior to dacarbazine. And it's being written up at the moment, and we presented the poster at ASCO recently. Now that negative is really important, I think, because Sato, they still want to do studies with Sunitinib on the basis of non-robust evidence. And when I was presenting this poster in America, there were a few American investigators who came up to me, because it's a small community, saying, "Thank you for doing this study, because it means that patients aren't going to be exposed to what is a toxic drug unnecessarily." So obviously, we always hope for the positive outcome for a clinical trial, but negative outcomes for trials are really important in focusing attention on things that have got more potential, and not wasting time and wasting patients' time and wasting patients' lives sometimes by messing about with drugs that aren't showing any benefit. So the negative is important. We put 84 patients on in the country onto the SWAV study, and that's a very major effort, and that ranks very well competitively with other networks around the world. And it's really that effort has made the UK a very attractive place to perform ocular melanoma research, and I strongly believe that that's for our patients' benefit, because you will see that we are now attracting drugs that I'm hopeful for will make a difference. So if we just move on to where the field's going now with ocular melanoma, we now realise that there are specific activating mutations in ocular melanoma that drive the cancer cells, and many of you will be aware of a couple of oncogenes. One's called GNAQ, the other one's called GNA11, and together, in around 80% or so of patients with uveal melanoma, these genes are activated, they've been mutated, the switch has been stuck on when it shouldn't be, and these are stimulating the cancer cells to grow. So we can start thinking about drugs which inhibit those pathways that have been turned on when they shouldn't be. So if one's thinking about a targeted therapy, it's not just taking any old drug or any targeted drug and throwing it at patients. I mean, one wants to know that your drug is selective and that it's potent enough. You need to know that it has a toxicity profile that's acceptable. Ideally, you need to work out the resistance mechanisms, because cancer cells are very good through Darwinian selection at avoiding or learning how to avoid the suppressive effects of anything you throw at them. So working out how they do that would instruct how to treat resistant disease, and ideally how to delay the onset of resistance. And that feeds into decisions around whether one should use combinations of targeted drugs or use them in sequence. And one also wants to know how frequently the target is in the population. If you've got 80% of ocular melanomas having mutations in GNAC or GNA11, that's very attractive, because you know that you'll be able to potentially have an impact upon the majority of patients if you have appropriately potent drugs. But if one found if you found a rarer mutation in 5% or 10% of ocular melanoma patients, you're down at the 10 to 20 patients in the UK per year of having benefit, and it would be perhaps difficult to develop a drug under that setting. And finally, if you are going to do work in a targeted population, in other words, only treat patients whose disease has got the target for the drug, you need to be able to have a test that you can use in practical terms to identify that the target's there in real time, and not wait 6 months before you have the result of the test back before you treat the patient, because these patients need treating within a few weeks. So things have moved on substantially, and this really is an exciting time, I think, because we're seeing the first clinical evidence of benefit with targeted treatments for ocular melanoma. And a colleague, Rich Carvajal from Memorial, presented this data in the summer, which was a phase 2 study of Selumetinib, which is an AstraZeneca MEK inhibitor, and I'll show you why that's important, compared to patients receiving chemotherapy. In fact, they received temozolomide or dacarbazine with advanced ocular melanoma. So forgive me for these wiring diagrams. Basically, what I want to show you is this is the cell membrane, this is the outside of the cell, this is the inside of the cell. And I mentioned GNAQ and GNA11. These are up here in the cell membrane, and they're switched on when they shouldn't be. And when they're switched on, they feed down this signaling pathway. And the drugs that I'm going to be mentioning a lot about, MEK inhibitors, block this molecule here. So you can see that you've got this activated pathway. And if you've got a drug that blocks the pathway, ideally, you hope, you stop the effects of this stimulation from above. Okay? So Selumetinib is a drug which inhibits MEK. And in laboratory experiments, it was found to be active. And in a subset of 20 patients treated on an earlier trial, there was some evidence of benefit. So time to progression for patients receiving Selumetinib was 16 weeks compared to 7 weeks for temozolomide. So Rich and his colleagues ran this study. So this was a study in patients who had not previously had chemotherapy, and they either received chemotherapy or Selumetinib. And then upon progression, those who received the chemotherapy could switch over to the Selumetinib. So we know about, so there are about 100 patients randomized, half received chemotherapy and half received Selumetinib, but 40 of those who originally received the chemotherapy crossed over to receive the Selumetinib at a later date. We know quite a lot about this class of drugs, and they're often associated with rash. You can have some eye problems and some heart problems, but they are pretty well tolerated compared to the majority of oncological agents that we use. And these are the waterfall plots. So each column is the tumour burden in an individual patient. So if the columns are going up, the cancer is growing. If the columns are going down, the cancer is shrinking. Okay. So you can see for these chemotherapy patients, the vast majority of these tumours were growing. There were a few who responded to chemotherapy. But in these patients who received Selumetinib, about half of these patients had some tumour shrinkage. Okay, so that's a very different signal. That's very exciting in a disease that's really quite refractory to conventional oncological treatments. And when you look at the progression-free survival, so the time before the cancer started growing, that's really what it means. As you can see, there was an improvement in the median progression-free survival from 7 weeks to nearly 16 weeks. So approximately, you double the time before the cancer grows from 2 months to 4 months. So that's the average, that's the median. Obviously, 4 months before the cancer starts growing, that's not what we aspire to. We want much more than that. But it's a very strong signal. You've doubled the benefit. And so as a foundation to build further improvements on, that's, I think, very important. There wasn't an overall survival benefit, but remember, 90% of the patients or 80% of the patients who received chemotherapy switched over to receive Selumetinib. So, in other words, 90% of everybody on this trial had Selumetinib at some point or other. So it's difficult. So you wouldn't expect really there to be an overall survival readout. So that was a very important study. Now, the problem with that study is it was an academic study, and the way it was run was inadequate for the licensing authorities, the FDA and the MHRA, to say, okay, there's enough evidence for you to use Selumetinib for this. So there needs to be a further study, a registration study, where the data is robustly collected to convince the licensing authorities that this should become a standard of care for patients with advanced uveal melanoma. So that study is going to open over the next couple of months. Rich Carvajal is running it is the senior investigator and running it across all territories. I'm running it for the UK. And it's comparing Selumetinib with dacarbazine. Now, when I describe this to patients, they'll say, God, we've had enough of dacarbazine. Why are you still exposing us to this drug? And the point is, the ethical point here is that for a new treatment to be adopted, it's got to be proved to be better than what's currently available. If you don't do that, then the FDA and the MHRA won't approve it, and NICE won't approve it, and the ethical issue for all the future patients for the next 5 years is major, because they wouldn't have access to the drug if the data is not collected in a way that allows the drug to be registered. So the design of this study is, as you would expect, that patients who end up being randomized to the dacarbazine, upon the growth of their disease, will be allowed to cross over to receive the Selumetinib. But we hope that this will generate the data that's required to go to the licensing authorities to say, yes, this is superior from compared to what we've had before, and therefore it should be available. Now, there is another MEK inhibitor, a drug called Trametinib, made by a different company called GlaxoSmithKline. And in their phase 1 study, they had 16 patients with uveal melanoma, and some of them did have significant benefit. They thought it was a negative study originally, but it wasn't. I think it was positive. And it's led on to this other study, which is being run through something called the International Rare Cancers Initiative, IRCI. And that's a collaborative effort between the UK, and Ernie Marshall is leading that for the UK. So the UK, the ERTC, and the National Cancer Institute in the States. And this is a study that, again, will be open before the end of the year, that's looking at the GSK MEK inhibitor, Trametinib, either alone or in combination with another one of their drugs, an AKT inhibitor. So because we've demonstrated that the UK can do these studies now, we will have 2 studies opening before the end of the year, one with Selumetinib, for which there is more evidence than any other drug available in ocular melanoma that it has activity. And another study with Trametinib, and there's 16 patients only treated, but we're hopeful that it's active. And those studies will be open at 4 to 5 centres each across the UK, so there'll be 8 to 10 centres across the UK running these studies. We've said that one centre shouldn't run 2 studies because of the rarity of the tumour, but both studies will be being run in the UK. And that's, I think, a real opportunity for patients and important for us. It's obviously important for individual patients, but it's important in how we move the field forward. So we're already planning on what happens next, and we've put in an application to CTAC to build upon the Selumetinib experience. CTAC is the Clinical Trials Awards Advisory Committee, which is a CR UK committee that provides money to run clinical trials. We've developed an academic study following on from the 2 studies I've just mentioned that's using Selumetinib in combination with this class of chemotherapy drugs called a taxane, because there's laboratory evidence that when you expose cancer cells to a MEK inhibitor and to this class of chemotherapy drugs called taxanes, that the anti-tumour effect of taxane is markedly increased by the presence of the MEK inhibitor. And we think because ocular melanoma it seems that MEK signalling is an important component for the growth of ocular melanoma, we're hopeful that this strategy could be active and beneficial. So the trial that we're designing, this is the CELPAC study, looks at Selumetinib on its own compared to Selumetinib versus a conventional dose of chemotherapy with Taxol versus the same combination, but we are just withdrawing the Selumetinib just before the Taxol goes in, because there's a little bit of laboratory evidence that by doing that we can increase the cell kill. So this is an academic study that we're putting through the clinical studies group. We've got support from AstraZeneca to do it. We'll see what the CR UK decision is next month, or in November. But you can see one thing from this study. The control arm here is Selumetinib. Okay, so the way that we've designed this study is in the hope that by the time we come to this point, we would have dispensed having to use dacarbazine as a standard of care, because we're hopeful that the registration study with Selumetinib will confirm Rich Carvajal's observations, and that Selumetinib will become the standard treatment, and therefore this is trying to build upon the new standard treatment we're looking in the future. So that's I hope evidence that things really are starting to move forward with these targeted agents. So I've mentioned that we've put in this proposal for the November meeting. I mentioned to Kath earlier that we require a patient rep for the trial steering committee for this. So I'll be leading the study. It's going to be run out of Liverpool, and the Liverpool Trials Unit has obviously generated a lot of experience now running trials for ocular melanoma patients. The majority of clinical trials now require steering committees to ensure the appropriate governance associated with running a clinical trial, and it's very important for us to have patient engagement with that process. So I've asked Catherine to let me know and if Catherine can act as a focus for anybody who's interested in considering joining the trial steering committee for the CELPAC study, and help us develop the study, develop the patient information sheets, and act and be an active representative within that governance committee, the steering committee for the study. So my final slide. So I'm hopeful that MEK-based targeted treatment will become the next standard of care, and I think that's likely to happen over the next year or so. Because we've got ourselves organised in the UK, it means that trials are now available for patients. And Kath mentioned the guidelines, and it's difficult to talk actively about the guidelines because we've got a draft that's going to be out for consultation shortly, and it was unfair on the committee to go into the details of that before the draft's out, but you won't be surprised to hear that one of the things that everybody feels strongly about is that patients should have access to clinical trials, and so that will certainly be within the guidance that we're developing. There are other targets and other agents under active investigation. I've focused on the areas that I think there's the most robust clinical evidence, but you won't be surprised to hear that there are other things coming through. But as I touched on, I really think it's important that all of these approaches, and not just the drug-based approaches, but whether it's the interventional radiology or anything else, they have to be properly assessed to gain quality evidence that allows us with confidence to say to a patient that this is in your best interest and not anecdote. And that's what this effort's all about. Thank you.
Thank you very much. We've just got time for a couple of quick questions if anybody did want to ask anything.
Thank you very much. Absolutely fascinating. Is there any room for going one step before that patients at risk can be included into clinical trials? So we have patients, and we now have the biopsy, it's monosomy 3, it's a high risk for developing but no sign of disease, and the question is, can't I go into a clinical trial to prevent any metastasis? Is there any room for that in the future?
Yes, very much. So absolutely is the short answer. So those studies are called adjuvant clinical trials. So the idea is, you've got a high-risk patient population. You know that half of them will have microscopic cancer cells hiding somewhere in their body. And those are the half of patients that over the following months and years will ultimately relapse with recurrent disease. And so that's why breast cancer patients and colon cancer patients after surgery have chemotherapy to try to reduce that risk of recurrence for the future. So the first thing that you need is an active drug. And when you look at drug development in oncology, what tends to happen is that you need to take your most active drugs from the metastatic setting, and then you can start looking at them in the adjuvant preventative setting. And the problem with ocular melanoma is that we haven't had any active drugs in the metastatic setting. Now that's changing, and so I think if we go on to prove that these agents are helpful in the metastatic setting, then certainly there'd want to be adjuvant studies. The other thing that feeds into it is that MEK inhibitors in combination with BRAF inhibitors are also being looked at in the adjuvant setting for cutaneous melanoma. We'll probably have those readouts before. And I know it's a different disease, but it will build confidence if you can show that you've got benefit in terms of disease prevention for that group of patients. It'll give confidence in using these drugs for ocular patients. Two other points on that. First of all, because of the rarity of the patients, one certainly would want to look at the high-risk group and not in an unselected population. And then the second thing, I suppose that the only exception from using drugs that have proved themselves in the metastatic setting may be with immunotherapeutics, and maybe Christian will say something about that, because it may well be that an immunotherapy is more able to kill microscopic cancer cells than bulky lumps of tumour. And therefore, just because an immunotherapeutic hasn't been shown to be as helpful in advanced disease, that's not inherently a reason not to look at it in the preventative setting, because it's only a few microscopic cancer cells that need to be got rid of, and that may be exactly where immunotherapies may be more active.
If a patient has been on a trial and had a MEK inhibitor,
Yeah.
And it hasn't worked, is there a chance that if they had a MEK inhibitor by another drugs company, that it might just work because it's slightly different or whatever?
Yeah, it's a good question. There are two main candidates. Well, in fact, there are three candidates out there for MEK inhibitors. Generally, there's the two that I mentioned, and there's also a Novartis drug. And in fact, there is a trial with the Novartis drug in ocular melanoma as well. The drugs aren't identical, partly in the way that the body handles the drug. In other words, how quickly it's cleared from the system. And they're also not identical in their potency at the target. So Selumetinib is given twice a day because it gets out of the system quickly. Trametinib is given once a day, and the half-life of trametinib is measured in days, not hours, and it hangs around. Now that could be a good or a bad thing. We don't know. And so if the reason that the drug didn't work was because it wasn't potent enough, but the target was still a good target, then it's possible that a second type of MEK inhibitor could be beneficial. But if the drug didn't work because in that individual cancer, the MEK inhibitor, the MEK wasn't an important component of the growth of the cancer cell, then a second MEK inhibitor is not going to be helpful. And so the answer to your question is it's just trial and error. Personally, I think if somebody's failed a MEK inhibitor, I'd want to explore other options for that patient before coming back to an alternative MEK inhibitor, because my confidence that they would have useful further benefit from an alternative MEK inhibitor would be quite low, but it's not impossible.
And certainly the information we have from other combinations in other diseases, so CML with c-KIT inhibitors or lung cancer with EGF receptor inhibitors is very much like that.
Yeah.
So if one doesn't work, the others usually don't work either.
Yeah, I don't know if you heard that. So Christian was just saying, making parallels with other diseases, generally when you've got a disease that where you've got the options of a number of drugs within the same class, often retreating a patient's disease with another member of the same class isn't beneficial.